So, Stephen, is the mic working okay?
Yep. You're great.
Especially when I'm talking about alcohol.
I know, I'm all over alcohol. I'm like, uh-oh, Dian,
It's okay.
huh? Well, yeah, he's here right now, but we're waiting to get him picked up. Gary, just let us know when you've logged in, and if you want to hang up when you've logged in, so make sure you get in. I'll wait.
Okay, thank you. Because I'm not sure how much I'm capable of today.
Not that alcohol is right.
No. Oh.
I'm sorry? It is a big crowd.
Nah. Gary, I got about 15 sorries I can't come today, this morning. I'm sick. My dog has the flu.
My dog ate my homework. There's about 20 people here right now. We're about half full.
I'm here.
Were you able to log into the system? Yep. PowerPoint slide. You're good, and then the audio will come on shortly. So if you have headphones, if you want to listen to it that way through your computer, that would be great. I'm sorry, I missed that. Oh. You should be able to hear it from your speakers of your computer. So I'm going to disconnect you from this call because we'll get feedback if we have both of them going. Okay. And you're good?
And then we'll use the same number again when the presentation's over. We'll dial you into this number. Okay, Gary?
All right. Thanks for your patience. Okay. Bye-bye.
Oh, yeah.
Okay, welcome everyone. As you probably know, today is Dian's PhD dissertation defense. It's always an exciting time, and I know that she's been working hard, and I think we'll all be looking forward to it. As usual, we'll do the usual procedure where she'll give her presentation. The public will ask questions, then the public will be excused, leaving her and her committee, and then she'll be excused, and the committee will render their final judgment. Not to put any pressure on her. Not to put any pressure on her. And anyways, it's been a long road, and Dian's been here for a while, and it's always fun to see people reach these milestones. Let me just give a brief introduction. I know that most of you know her, but she received her bachelor's degree from UC Irvine with a double major in economics and mathematics, and then received her MBA from a French institution whose only acronym I'll pronounce, which is INSEAD. And then she received a Master of Science in Nursing an advanced registered nurse practitioner degree from Seattle University, where she had some other jobs along the way, also ended up teaching there, and doing other work around the Puget Sound area. And then she joined our program as a PhD student, and as if all of this is not enough, she's also been spending time working as a clinician, as a nurse practitioner at Old Town Clinic, which is a clinic for the underserved in Portland. So I will turn it over to Dian.
Thank you, Bill. Thank you all for coming. I'm delighted to see you here, and I'm delighted to be able to talk about the work I've done, as Bill said, over the last 43 months. But who's counting? It started with a term paper in Bill's 610 class, Introduction to Bioinformatics, and I've gotten a tremendous amount of help along the way, and I'm very grateful. In March of 2011, I met with a lot of you. We did a presentation that's online. You can find it on the On Informatics blog, where I talked about my lit review behind this work. In January of 2012, I presented my methods. You can find that also in Informatics. Today I'm going to focus more on methods and the results that came from them. It's only 40 minutes. I would really like to have an interactive talk, but I've got a lot to cover, so I'm going to ask you to hold your questions to the end. It's okay with you. So when I talked to you before, I mentioned that there were some really key drivers that are changing what we do in healthcare, particularly in primary care. And those key drivers are that the rising prevalence of chronic disease is resulting in a change in the requirements for healthcare. We're having more visits, and these visits are requiring more specialized skills. So all of a sudden it's beyond what one provider can do. We're overloading the system. So we're having to work more in teams. And increasingly the EHR is becoming an important part of supporting that work to try and achieve the triple aim. This collaboration needs to take place not only in the primary care clinic, which is being redone as the patient-centered medical home, but it needs to be done within the... All right, Dr. Gorman. Delighted to see you. Being done within the neighborhood. In other words, we need to improve the collaboration not just on a team basis within the clinic, but with the specialists that are outside the clinic. And I think that's an important area that's been understudied. One of the things, this room is wonderful because everybody has to walk in the front. I love it. Come on in, Laura. One of the things that kind of bears in mind or reinforces what I told you 2 years ago is that a major effort that's going on by CMS, the people that bring you Medicare, is called the Comprehensive Primary Care Initiative. And what that is, it's a large demonstration project, over 300,000 Medicare recipients in 7 states, designed around implementing and trying to improve the effectiveness of the patient-centered medical home. These clinics are getting additional payments that are not fee-based, but are rather based upon the people they're taking care of. And to be in this program, they had to meet some requirements. They had to provide 24-hour medical care guided by the medical record. I'd like to see you do that with a paper chart. They had to provide population-based approach with care teams and managers responsible. It had to be a team approach, looking at the overall panel. Team-based care. And it had to provide coordination of care across that medical neighborhood with the primary care provider, PCP as primary care provider, as lead, with clear mechanisms for data interchange. Sounds like another role for health information technology. What we talked about 2 years ago is happening today. The interaction of the electronic health record in collaboration has been understudied. We've got some good formative work. I mean, Joe Nash here has done a lot of it on unintended consequences. It's a concept that comes from system theory that when you implement a system, it's going to have consequences you could not predict, good or bad, in their surrounding systems. And she and others have done some excellent work in this area. Coera, as early as 2000, actually looked at using the EHR as a communication vehicle. And his conclusion was, there are times that sometimes you just got to talk. You can't look at the computer and replace all communications. It's not a rich enough channel. Their work on the interaction is just beginning to emerge. Notable work is work done by Weir, MB, Hammond, and a group that's been working with focus groups at VA sites around the country. And they've done qualitative work that has taken a look at how the use of the EHR has increased common ground, that basis of understanding between clinicians, that it has in some cases exacerbated tensions between roles, particularly between management and providers, because all of a sudden managers are able to see better and critique providers. And also that the EHR's performance issues, quality of data, miscommunications, actually have negative effects on collaboration behaviors. Jordan Lanham did a study in a large health system in Texas where she looked at EHR and communication. And her conclusion is that even though they had one EHR, different providers and different practices had very different communication patterns with widely varying degrees of effectiveness. Just having an EHR doesn't assure a common communication system. Very little work on quantitative effects of the EHR. One thing I found from Mathematica as part of an overall study of the effects of the EHR was they said that in a physician survey, they found that providers believed that use of the EHR improved their communications not within the clinic, no change there, but with people outside the clinic. One of the reasons we may be having difficulties getting the quantitative data is that we don't have very good instruments for measuring across the boundaries within and without the clinic. There's an article in press that's been accepted for publication in Medical Care by Valentine that actually looks at the surveys we have available to look at collaboration in healthcare and to see which ones are validated and will work across the clinic boundaries. She found two. She found one by Kalish that actually focuses on nurses, looks at nurses' teamwork across boundaries. And she found a second one by Jody Hoffer-Cattell that looks at relational coordination. And that's actually a combination of communication and trust and respect, goal sharing, and one other factor, I'm trying to remember it. Okay, but in goal sharing, and it's basically an overall trust measure and a communication measure. There are other tools. I mean, AHRQ put out an atlas, a 300-page atlas, all different kinds of coordination tools. She looked at them and found they weren't valid. One of the tools in there is one by Judith Baggs, who's here at OHSU. And Judith was good enough to spend some time with me talking to you about her measure. And she's got a measure that she developed that looked at nurses in the ICU and how they work with physicians. Good study, doesn't work in this setting. Ron Stock has a team development measure that focuses on how teams are working together within the clinic. And here we've got a difference because this is a survey that focuses a lot on the antecedents, the behaviors and situations that make people more collaborative rather than the actual collaborative behavior. And finally, Gary Olson was good enough to share with me his collaboration wizard, where he actually was working on that distance problem, how you collaborate across distance, for researchers. And it was based upon a common ground model. You know, once again, look at the antecedents. So there are instruments out there I was able to look at, but none that quite fit what I wanted. So I ended up with 3 research questions I'm going to be talking about today. First of all is to trying to understand the broad framework. How does the AHR affect the way clinicians work together? By clinicians, I mean people who can change care plans. And this was actually qualitative today, trying to look at the big picture. How can we measure collaboration behaviors? Behaviors, not the antecedents, both within and out the clinic. And finally, can we quantitatively take a look at the effects of increases in the use of DHR and other communication channels on collaboration behaviors? Those are my 3 questions. So 3 questions, 3 phases. The first phase was a broad overview look, trying to, in an unbiased way, get an idea of the field, understand some of the things that are going on between collaboration and the EHR. I've been lucky enough to be part of the POET team for the past 3 years, headed by Joan Ash. And the POET team was given the assignment by the Office of the National Coordinator for HIT to develop guidelines for the safe usage of the electronic health record. As part of that, we got to go to 5 different sites around the country that had successfully implemented the EHR. We did a lot of things, but among the things we did, I got to take part in 49 interviews where we asked questions based on an open-ended, semi-structured questionnaire I developed about collaboration behaviors in the EHR. I and others on the team also got to spend 60 hours of field observation, watching people use the EHR, providers use the EHR, and their collaboration that way. And I'll talk more about the analysis methods in just a minute. Okay, in phase 2, we actually worked to answer that question, can we develop a measure, by developing an instrument here at OHSU, both within the department and within the GIM clinic. And then once we had it developed, then we went to validate it at a clinic here in Portland. And then the third phase was actually more of an application. Can we apply this to try and look at what channels are working? In this phase, David Dorr was kind enough and his TopMed team to work with me and TopMed, by the means, stands for Transforming Outcomes for Patients Through Medical Home Evaluation and Redesign. Did I get it right? Pretty close? Okay. So we got to go to 8 clinics using 4 different EHRs, widely different sizes throughout Oregon. But the common denominator is they're all implementing the patient-centered medical home. So collaboration would be an interest to them. And this was a purely quantitative survey effort. So looking at the first phase, or aim, how does the EHR affect collaboration providers? There's a challenge here. We all, and probably me especially, bring to our work biases. We have preconceived notions, there are things we've read. How do we try and set them aside and get an unbiased view on what's going on? Well, one thing, and I had a tough project leader, Dr. Ash, who insisted I write biasing memos before I did my work. Okay? So be aware of what you've got and try and guard against it. Second is working as a team is helpful. Our team had people from all different disciplines and a lot of different viewpoints, and people who weren't afraid to speak out when they disagreed. So that was a very valuable part of the exercise. And then the way we collected the data, using open-ended questions, recording the transcripts, and we'll talk about in a second the way we analyze the data. Once again, trying to guard against biases. And to the extent possible, we did grounded theory analysis. And I've read Glaser and Strauss and Corbin, and I would argue that you can never be completely grounded. You're always bringing something to it, but we try to be, where possible, start from ground up. Which meant that we did ethnographic data collection at the beginning, and then we did exit interviews with the key informants to verify what we found on our way out. Then once we had the data transcribed, two analysts, myself and Jennifer Hall, who's currently in the Department of Family Medicine, separately coded the data, and then we met to reconcile it to form a code book. We did this after each set of transcripts came in. Then once we had our coding results, we condensed them, and we convened an expert panel. We actually convened the panel twice to try and review that panel and develop the themes from that work. And the themes that came up were that there were 4 roles for the EHR, was one of the ones we came up with. One of the roles is the original role for the EHR. The EHR was originally intended as a repository. It's where all the data goes, where you can find everything. Hopefully you can find it. Maybe harder at times than others. The second role is that of a messenger. And if you read, like Larry Weed on the paper chart, the idea behind the paper chart was it was supposed to support communication. It wasn't a communication channel. There was no intent that I would send my channel, my progress note across the street. It would provide the basis for me doing a letter or a report. When we talk to clinicians, however, one common thing they'd say is, oh, I communicate with that other person by sending them a copy of my progress note. Okay? So it's become a channel. I think it's a little bit more than we originally anticipated for the HR to do. But the HR has changed even more from the paper chart. When you think about the way we set up templates, templates in their own way can prescribe the workflow and who does what. The fact that an MA can enter the vitals and a provider doesn't. The fact that a provider has to enter the diagnosis or the orders. It describes the workflow. It starts to structure the work itself, the collaboration. But it's more than that. As we've developed computerized provider order entry, we're getting some pretty sophisticated algorithms that define who does what when much more explicitly. And there are even bundles. Like one of the ones, people we talked to had a bundle for diabetes that would issue 400 orders over a 6-month period based upon assigning a diagnosis of diabetes type 2 and a goal of 8% A1C. They range from getting lab exams to actually having an endocrinology follow-up if they weren't within target in the 6 months. All authorized by the fact that the provider said, problem, diabetes 2, A1C goal 8%, I authorize protocol. It's become the orchestrator, making sure the right person is the right thing at the right time. And finally, it's a monitor. With the EHR, we're able to create registries and track how people are doing on conditions. We're also able to create dashboards so teams can see how they're doing. You know, green they're doing good, red they're having problems, maybe a yellow if they're not. But that dashboards are commonly shared between members of the team. So all of a sudden we've got a monitor that says how we're doing. And a little less helpful sometimes is we're also getting the results up the chain to clinic leadership and management. That can create some tension. These behaviors map directly, roles map directly to collaboration behaviors. How well we do the documentation, how well we put stuff in the repository, how findable it is, affects directly trust and respect. How well we do the messenger affects communication. The orchestrator affects how well we can coordinate. And the monitor can affect how well we can tailor solutions, how well we can adapt what we do to meet specific needs. For example, some comments we got on the repository trust and respect pairing is, yeah, everybody said it's great, it's all there. May not be able to find it, but it's all there. Okay? They told us that occasionally there were problems. A big complaint we got was on the copy and paste function. You know, in one case we were looking at a very long note and a very frustrated clinician who said, everything in this note is either fabrication is correct 2 years ago, but not today. Cut and paste can promote errors that occur for a long time. And on the other side, a CMIO told us, You know, that's not new. We just have more visibility. People who wrote good notes in a paper error still write good notes in electronic error. It's just it's more visible now. As a messenger function, a podiatrist in the community health center said, it's great. All I have to do is write a brief note, attach my EHR progress note, and send it to the provider. It's really quick, much better than trying to call or write. And it can also increase this cognitive awareness, looking at nurses. We know the attending is checking the vitals, even though he's not in the room, and we know he'll come when he needs to. Gives us a way to start doing some distributed cognitive awareness. Nathan? Okay, but there's some contraries, and one of them we heard in several places was that when you implement an EHR, people can forget that they can talk to each other. They called it brain freeze. And they said we put the EHR in, and then 3 months later we had to go back and do retraining and tell people, yes, you can still pick up the phone and call. We talked about the idea of using bundles. One system we talked to said they're actually using a preventative care bundle for 220,000 patients to automatically order things like PAP screens or A1C. They talked about using the EHR and its associated tools to try and make sure they've got the right person doing the right thing at the right time. And that's often related to having people working at the top of their license. One of the problems we heard is these are great tools, but they can take time to do. And as one person told us, you can have a great tool for asthma, but if it takes 10 minutes to do, it isn't going to happen. Providers just don't have the time in a 15 to 20-minute visit to do it. Sorry. And finally, for the monitor function, it can drive adaptation. If you roll out the measures, people see there's a problem, and they can work to try and fix it. They can change their workflow. They can change their approach to a specific patient. One issue is trying to make sure that your goals are perceived as valid. A place we looked at that was paying incentives off of their performance on the measure of the EHR paid incentives if it was below 7%, but at 7% they didn't pay an incentive. That was perceived as being maybe not too credible and caused some discontent. So overall, we found that the EHR was an important actor in collaboration processes, that the roles tied to collaboration behaviors, that healthcare collaboration was not a single behavior but was several, and finally that the EHR's performance in one role can have some trickle-down effects on performance in other areas. The second question was, can we develop a generalized tool to measure healthcare collaboration behaviors? And it was important to be generalized because the roles are changing in healthcare. People are doing things they didn't do professionals 10 years ago. We wanted it to be brief. One of the things that we found in our process is it's really hard to get providers to do anything. It takes over about 5 minutes to do. We want it to be valid for both co-located and distant collaborations, reliable, profession neutral. We wanted to have both paper and online versions, depending upon what the work of the clinic. And we want it to be focused on behaviors, not on the antecedents of behaviors. This is not meant necessarily to be a standalone survey, but one just saying, here's what is going on. So you can measure validity in a lot of different ways: face, content, convergent, construct, and criterion. The Valentine article said that most people only show 2 or 3 of those. We're actually trying to show 5, one of which is actually going to come, the last one, criterion, is going to come in our next phase. We also want to look at reliability. Do we have a bias, for example, between the online and the paper versions? Are the factors homogeneous? In other words, if we look at the things we're saying were measured, are they all measuring the same thing, or are they measuring different things? And finally, is it reliable? How much of the variance is being captured by the instrument we're using? So the process we had was, our original draft was based upon the formative work we did, the work we did in the SAFER project. It was based upon theory, and the theory I actually drew a lot from Salas, Clancy, and Kidman and Blake. And also the review of existing instruments. Based on that, we, and then Dave actually helped me here, developed a draft instrument, which we then went and we tested. We started off by testing it with 7 people here within the department, providers within the clinicians within the department. Based upon that, in congruence with what Nielsen suggested, we actually stopped, revised it, redid it, and rolled it out again with another 7, this time out in the GIM clinic. That gave us an instrument that looked fairly good. We took it to the GIM group, the Research in Progress group, and we got 3 pages of comments, and thank enough for taking those comments. So on the clinic, we reflected that, and then we took it to an expert panel who did a Delphi process of looking at it first, then commenting, and then bringing it all together to try and make sure that we had content validity, that we actually covered the waterfront, that our domain was, questions were applicable to the domains we said, and we covered the domain. The resulting tool is an instrument, rather, has 2 parts, because we wanted to also look at the application. The first part, the instrument, looks at collaboration behaviors. The second looks at communication channel use frequency. Both are gesture scales, like Likert scale, and we asked participants to rate the frequency of the behavior on a scale from 1 to 9, where 1 was never and 9 was always, 5 was sometimes. We also gave them the 10th option, don't know, which we then coded in our data analysis as missing data. We didn't try to impute there. Okay, looking at the administration, we solicited 21 of the 21 clinicians that were in the clinic at the time for our validation study. They all participated, one of whom did not do the online version, so we actually got 41 surveys back. Each survey had 2 collaborations, so we actually got the rating on 82 collaborations. You know, each survey, and I should have said this before, back up. You can see the other thing it does is we actually ask them to rate both a co-located, both your last significant co-located collaboration and your last significant collaboration with an outside professional. So we got 2 per survey instrument. Thank you. Okay, and of the 82, 14 were test-retest, take the same collaboration and do it, and 68 were unique. Okay, now the statisticians in this group, I'm sure, are going, you can't do that. You're getting 4 responses from the same person. The data's not independent. Okay, well, yeah, that's right. So we had to do something different. There are 2 ways to approach it. One is to look at it in terms of multi-level analysis. In that case, what we did is we said that the data is clustered. We had groups of 4 and 1 of 2. And we tried to do is we actually tried to break it down into the actual observation they gave us, like they might rate it a 7. And then there was a true response plus an individual bias. You know the way some people will always, you ask them how they're doing, they go, great. And some people go, that's okay. Individual bias, same day, different observer. By getting multiple observations, we're able to estimate a correction factor for that using multi-level analysis. Okay, as an alternative, a different way to handle the same problem, what you can do is you can actually calculate how much that clustering changes by looking at the interclass correlation, and you can inflate your estimated variance, which makes it harder to show that your hypotheses are true, and use that. And we actually use both techniques in this process. The other technique we used was we used structural equation modeling. What this does is it allows us to describe the system in terms of equations and evaluate them all simultaneously, okay, using a maximum likelihood estimator. And the advantage of this is not just that it allows us to look at the whole thing all together, but it also gives us statistics for the fit of our model. How well does the overall model work, as opposed to just looking at piece by piece. So, you know, basically we had 4 factors: trust, communication, coordination, and adaptation. And in this case, I'm showing it based upon 8 questions. Some of the questions were reverse scored. Rather than asking, how often do you communicate effectively, we'd ask, how often do you not communicate effectively? Which means we had to reverse the answers. That's what the asterisk means. And what we found is if you're looking at how the responses are related, how homogeneous the factors are, that within the factors, we had good relationships. You know, our Cronbach's alpha, you can see, was between 0.7 and 0.8. But if we tried to add them together into a scale, it fell to 0.31, which suggests, like we had in our formative work, collaboration or different behaviors. We took a look at the results of co-located versus distance results, and we found co-located scores were higher than distance. This isn't a shock. This is something we knew all along. But what it does is it shows that, at least in this respect, the scale seems to be working. This is called convergent validity. My original assumption, the construct I was working on, was that this was what's called a Gutman scale. That you had a series of behaviors: trust, communication, coordination, adaptation, and you needed to have trust before you could do communication. You needed to have communication before you could do coordination. You needed coordination before adaptation. The way you test that is by looking at the coefficient of reproducibility, which says how often is the frequency of one behavior, a lower level behavior, higher than the higher behavior. And the standard is usually you want to be above 0.85. Didn't make it. You can see if you look at it, actually, coordination and adaptation was 0.51. Basically flip the coin. So I had to drop that one. But what we did find is the factors are related. That, okay, and the trust data, by the way, we had was skewed positively. So I had to bin the data into sometimes trust or less, to usually trust and always trust, the 3 categories, because it wasn't normally distributed. But being in the upper category of the trust scale meant that, on average, you were 1.4 steps higher in the communication scale. For every step you increased in the communication scale, you could expect to go up 0.29 steps in the coordination scale. And for every step in the coordination scale, you could expect to go up 0.49 in the adaptation scale. So there is a relationship. It is statistically significant at individual level. And if you look at the model overall, it's got a Ramsey RMSEA of 0.45, which is considered good. 0.1 is considered acceptable. Although the amount of the overall variance it explains is not that great. It's 0.25, and you'd actually want to have more. So there are other things going on besides this. But the model seems to work. Strong hypothesis, Gutman scale, no. Weak hypothesis, these factors are related, yes. Okay, just some other results. It was fairly brief. One of the things that took the most time was we had open-ended questions. Those took about a minute for them to do. Without those, it was under a 5-minute scale. It was generalizable. Everybody agreed that you could use it for everybody involved in planning care. We tried it later on to use it for MAs. It didn't work for MAs. About half of them couldn't complete it. And the ones that did, the psychometric properties were terrible. It was reliable. Split half mean difference was pretty low, 0.8%. Good correlation between the split halves. Cronbach's alpha we talked about. Reliability coefficient 0.65 to 0.85, so that's within an acceptable range. In paper online versions, bias less than 0.1%, so pretty good that way. And we talked about face validity, because that's where we're talking to the participants when we did the development. Content validity with our expert panel, convergent, our distance versus co-located, and construct, which is showing there is a model that supports what we're doing. We can quantitatively show that. Criteria we'll talk about in just a minute. I've got two mice. We also had open-ended questions, and what was interesting to me was the open-ended questions came out pretty uniformly. Distance, time, and the EHR factors. Being co-located is a big help for collaboration. Time is a barrier to collaboration, and the EHR helps. Okay, this is novel. I haven't seen a scale that actually looks at adaptation as a specific behavior, and behaviors purely rather than behaviors as antecedents, because most people have a theory about what's going to fix it, and they also want to do that. I didn't do that. This is not an instrument you can apply, give it once and apply it to an individual. It takes repeated measurements. Remember, each one is just a snapshot, and so it takes repeated measurements to try and get a valid aggregation. But I think it can be useful for groups in monitoring the effects of an intervention. But you got to keep in mind, higher collaboration may or may not be useful. Different behaviors. So the question is, what's going to be most helpful? Okay. Phase 3 question was, how does the use of the EHR and other communication channels affect collaboration behaviors? Here we use both multi-level regression analysis and SEM. We use the data from the study also to perform a criterion validation and refine our model. Okay, we had 74 participants. You can see the participation by clinic varied widely. We had a couple of large clinics. The PCPs, you can see, were the hubs within the clinic on collaborations. Outside, it was a little more diverse, but still the PCPs are pretty involved. Okay, these clinics also took the clinician staff questionnaire, which looks at adaptive reserve and other things, and they took the collaborative practices assessment test. And so, for example, on the results of that, Clinic F had the highest result, okay, and then Clinic C had the second highest result. We can rank them. So this shows the rankings in the CSQ and the CPAT, and the rankings for each of our factors. And the reason I show them separately is our factors are different behaviors, and you can't compare them. And if you look at it, there's a reasonably good correlation between, and in fact it's 90%, Spearman, on the CSQ, the CPT, and the trust factor. It falls down significantly when we look at the other behaviors. This makes sense if you think about what the studies do, because the CSQ and the CPT look at things like how much you trust the people you're working with. Some of the questions they ask. It's more general factors. Okay, we looked at the model again, and because we have more data, we could refine it. We were able to add, looking at the effects of collaboration managers, changes in roles. And changes in roles did have a significant effect on perceived collaboration variables. We took a look at, and this is combining data from 2 studies, on the association between the increase in collaboration channel usage with the increase in collaboration behaviors. A single arrow means, double arrows means both studies found this relationship. One study means just one arrow means one study found it. A dot means no relationship that was significant. I'll talk about in a second. Statistically significant. And a down means it was actually negatively correlated. That an increase in this channel resulted in a decrease in that was associated with a decrease in that collaboration behavior. As you can see, informal communications, i.e. being co-located, helped across the board, but we had some things that were detrimental. Faxes, for example, ended up in a decrease in perceived communication. Sending the EHR progress note, this was interesting. A decrease in trust that could be overwritten if you send a message or a flag saying, okay, look at what I'm sending you. Here's what to focus on. And in fact, that note could be very helpful for adaptation behaviors. Multidisciplinary meetings proved to be effective in most situations. The same 3 topics came in that are open-ended: distance, time, and the EHR with similar effects. And so with more data, we could actually do more analysis. One of the issues we had is some things were significant in one study and another. I'm not sure whether it was because I was underpowered. Looking at after the fact, my a posterior power was only about 53%. I'd hoped for higher, like 80. And it also could be due, though, not to the significance, but just to cultural implementation effects. That the way you implement an EHR, the culture you build within the clinic also makes a difference. So analysis of all three data sets says that collaboration behaviors are distinct. You can have one without the other, but it doesn't indicate how effective they'll be not being combined. There are studies that show that collaboration does have benefits, but it takes more time. What's the balancing act? What collaboration you need when? Okay, co-location improves collaboration. That's just a fact. But most practices can't afford to have all the specialists on site they need. Our data suggests that the EHR can start to help to bridge the gap if it's used as a messaging and a coordinator. But it also suggests that if the EHR has poor performance, it makes things worse. Similar to where an MP found. Okay, clinicians complained about the EHR, but in our first study, the qualitative study, nobody wanted to go back. And the open-ended comments from phase 2 and phase 3 were positive about the EHR's role in collaboration. The question is not to get rid of the EHR, but how do we make it better? Work I'd like to do going forward is look at the effects of collaboration behaviors on patient and process outcomes, examine how the implementation processes enhance or affect the collaboration behaviors, and finally, how do we set up a methodology for actually evaluating technology tools and looking at how they bridge distance and time. So EHR is here. It's a significant actor. We need to keep improving it. We now have a tool, I think, we can use to try and monitor how we're doing in that improvement process. And this will allow clinics to evaluate the interventions they're doing, including the use of the EHR. And finally, if we can increase the effectiveness of the EHR, we can help it meet its potential for improving the AAA outcomes, patient satisfaction, and effectiveness. The last 4 years have been, for me, at times frustrating, but generally very good. And I'm very appreciative of all the help I've gotten from people at OHSU. I mean, David has put up with a lot, and I appreciate it, and given me pretty constant and helpful guidance. And the TopMed team has also been very helpful. I thank you for your help. I see them in the back. Dr. Ash has been a mentor as well, and very valued. The POET team, great. Especially my cohort in crime on some of the interviews, Adam Wright and Jen Hall. And Debbie, of course, was also on that team, Debbie Cohen, member of my committee. She set up some formative experiences with me with the Richmond Clinic that I actually carried forward into this, and I appreciate it. Gary Olson was generous in sharing what the work he was doing on the collaboration wizard. He was also on my committee. Annette took the notes at the RIP meeting and has helped me along the way too. Gorman, you get the problem. Paul Gorman gets for a lot of the initial formative stuff. He was a big help there. And then on the other end, Rachel Dresbeck has been helpful to me in rewriting the articles. DMICE has been a great environment to work in. I appreciate the staff, the faculty, and my fellows. We're lucky here that we've got a great library. And I've gotten a lot of help from librarians here at OHSU and also some at PSU. I'm very grateful for that. And finally, this is all possible through the National Library of Medicine. I'm funded under a training grant, and I'm grateful for that. So with all that gratitude, I thank you, and I'm sure you've got questions.
We are streaming this, so press the button down so the little red light comes on.
Dr. Fletcher.
This is an environment I know you've worked in. What of your results did you find surprising?
Honestly, I was surprised at a couple things. I was surprised at the strength of the association we found between the flags and the notes, and actually the difference that could make in adaptive behaviors. I was also a little bit surprised that sending a note had a negative effect on its own. That surprised me. I was obviously surprised because I thought it was initially a Goofman scale. And I'm also a little bit disappointed from the sign of the effects when we looked at the model, including the care managers, that there's some frustration in those relationships. Nathan.
How do you define communication, and do you think it would be worthwhile to make a distinction between different types of communication, one-way versus two-way?
Okay. So the communication factor is actually looking at it in terms, the questions we asked were, and the first one was, how often do you get the information you need to care for your common patient from your collaborator? The second question, and this actually I changed in the development process because it was originally a mirror, was how often does time prevent you from giving the information your collaborator needs? And the third was, how aware are you of what your collaborator is doing with your patient? So we had those three questions, and those three made up the factor. Thank you. But yeah, and it was interesting because before I added the time, I always give the information, but once you mentioned time, people normalized it, and people started giving me a spread of data that was worthwhile. And that didn't happen with the coordination and with the adaptation questions.
Can you talk a little bit more about the data types that you used? Did you consider the data as ordinal, categorical?
That is a really good question and a part of an ongoing debate within the statistical community. The data I collected is obviously ordinal data on the survey. Okay, and there are two camps. One says that ordinal data, forget it. It's subjective. You can't use it. Go away. Don't bother me. Another camp, which is a camp to which I subscribe and which I've seen some useful research for, says ordinal data can be usable if it has a wide enough range of values and if the distribution is such that it approximates a normal distribution. So that before I could use this data as regular, normally distributed data, I actually had to run tests, Wilk-Shapiro and Comographs, to try and make sure I had a normal distribution. And when I did that, I found the trust data did not fill that requirement, which is why I ended up dividing it into a categorical variable with 3 values. That answer your question? Okay, Dr. Hirsch.
Interesting. So, well, I was intrigued by your comment at the end. Maybe not intrigued, but just tying this to outcomes. So that makes a lot of sense for future research. Seeing how well collaboration, communication influence outcomes. It looks like your data, your instruments kind of give you some sort of overall measure. Do your instruments allow you to actually tease out specific things? So, maybe this clinic has lesser collaboration, although maybe they communicate better, so that you could start to maybe develop some hypotheses on kind of future work of, if we make this intervention to help them communicate better, this will lead to better outcomes.
Exactly. What Dr. Hirsch, if I understood what you're saying, is the fact that we have different behavior factors, if you will, means that we can all of a sudden take a look and see which of the behaviors is necessary to achieve better outcomes, rather than just saying that better collaboration is necessary. And I think that's absolutely right. And in fact, but the data also, one of the reasons I did something different is I actually asked for going and coming. And normally you don't do that. Normally you ask about going only because it's harder to evaluate, or coming only, is because these relationships are often asymmetrical. For example, a care manager is more likely to change their schedule and coordinate than a provider. And it's important to look at the symmetry between those behaviors too. So yes, what you're saying is absolutely right, and I think it'd be fascinating to look at how these changes in patterns affect outcomes and process efficiency.
So, okay, I mean, I just want to clarify. So, I mean, your instruments will give you the ability to measure specific aspects of those things, or your instrument does give you that, does or doesn't?
Absolutely, it does, and I would argue that it actually cannot be used as a total score because you can't add apples and Chevrolets. It just won't work, and that's what we have for collaboration behaviors. Diane, you had or Karen, you had a question?
You already answered my question.
Dr. Cohen.
Do you do any, comparison of different institutions and so you've got 4 different measures basically. So, what are your thoughts on not necessarily how to combine them into one number, but how to look at them, as a whole, and then, compare one group or one institution to another, sort of looking forward towards using it to correlate with outcomes.
The problem is, I'm not sure that increased adaptation is always a good thing. It takes a lot of time to tailor a plan. And if you look at people who are doing bundles, what they're actually doing is they're doing coordination on a huge scale, but it's pretty much, let's call it evidence-based, guideline-based practice as opposed to tailored practice. I think it's up in the air whether or not that's an important question. I think it's up in the air how much time we want to spend. When I send something to a radiologist, how much of a report do I want to give them to be effective and efficient? Probably more than we're giving them now, but not enough. And so what I'm saying is we can give the reports and the behaviors, but I'm not sure that you can say that there's one standard that's going to apply to everybody, and you're not, I'm sorry, your clinic is not at the gold standard, Dr. Cohen. I can't do that. I don't think we've got the evidence to do that at this point.
Yeah, I wasn't suggesting that as much as maybe there are combinations of profiles that might be more associated with certain outcomes or others. Not necessarily that more of everything is better, but some mixtures might be more effective than other mixtures. I
think that's cool. I haven't looked at it, but that is a cool idea. And I don't have enough data to do it here, but I really, that could be an interesting, let's add that to the list. Other questions? And you're still awake. Laura?
Your work is fascinating across several disciplines. I'm interested in knowing if you have already been in contact with different groups that look at quality improvement in the healthcare system, as well as organizations that deal with organizational behavior, because I think that this study would be of interest to both sets of those peoples.
I haven't. I'm just trying to get my dissertation done. Thank you. Thank you all for coming. Have a good day.
As we said, the committee needs to stay. Everybody else, if you can just take your conversations outside, it'd be very helpful to us.
Okay, so,
good job.
Thank you. Bill, thank you for everything.